Okay, you guys, this is the rest of the PowerPoint that was missed earlier this week on 115. We're going to get to meconium aspiration, and then we'll start with meconium aspiration in class on next week. All right, so acquired disorders versus congenital disorders. Hopefully this is something that you already understand since you are graduating soon. Acquired disorders are things that are usually occur at or soon after birth, and it could be due to delivery or something related to the birth process. Congenital are things that are present at birth but are typically developed in being while that baby is developing. This is things like cardiac issues to trisomy 21, other things along those lines. All right, so this is the list of acquired conditions of the newborn. The ones that are in bold, we will be talking about in this PowerPoint. The ones that are underlined, we will be talking about at some point throughout the program or the rest of the semester with me. And the ones that are not marked, we have already talked about, or it's like retinopathy of prematurity. We won't cover, but it is something very interesting. If you want to go into neonatal nursing, you might want to check that out on your own. All right, neonatal asphyxia. So this is when the baby has failure to establish some sort of adequate respirations. This can happen while the baby is still in utero, it can happen while the baby is delivering, or it can happen soon after birth. This baby doesn't get significant oxygen, so they have impaired gas exchange, which then lead what we might initially see in this baby while in utero or soon after birth is they may be showing signs of tachycardia, and could be vasoconstriction going on. Next thing we'll notice is they're quickly going into hypotension and bradycardia. And next, we will see cardiopulmonary arrest if we do not react soon enough. So this is where we're doing those resuscitative efforts of stimulation and more. Things that could lead to asphyxia in these babies, hypoxia in mom, or moms that have respiratory anemia or heart conditions, hypertension, vascular disease in the mom. Things like prolapsed cord or compressed cord can also lead to this. Okay. We're going to assess the baby's color, their work of breathing, their heart rate, their temperature. We want to make sure we're doing good APGAR scoring. We want to make sure we are keeping this baby warm. We're going to make sure that we are keeping a low stim environment. We are going to closely observe them. We're going to check their blood sugar so that we can tell if their sugars are dropping. We also will keep a close eye on them for cold stress. So if we can keep them warm, hopefully we won't do that. We may also draw some other labs on them as well. We're going to support the parents and let them know what's going on. It's not uncommon for these babies to just have a short period of neonatal asphyxia. We watch them for a few hours, then they seem to perk up, and sometimes they can just go over to mother baby and hang out with mom then and go home at a normal time. Some will struggle a little bit more and have to be watched in the NICU. It is not uncommon for us to find metabolic or respiratory acidosis in these kids, and if those things are going on and not corrected quickly, they will need to go to the NICU. So we briefly learned about transient tachypnea of the newborn in Care of the Growing Family. A little bit more about it. It is a mild respiratory distress when it is caused by that pulmonary liquid to not be removed from the lungs during the birthing process. So things that could lead to this: C-section, macrosomia, multiple gestations, moms that are sedated, prolonged or precipitous fast delivery, boys boy babies, moms with diabetes and asthma. These kids' ABGs, when we draw them, will be mildly hypoxic with an elevated CO2 just slightly, and their pH will be normal. We're going to see grunting, or hear grunting. We're going to see some tachypnea. We're going to see some retractions, nasal flaring, some cyanosis. These babies' respiratory rates will be 100, 150, or 120, 140. Their little chests are going to be bouncing up and down really fast because they're breathing so quickly. If I were to listen to their lungs, it's going to be slightly decreased aeration. We're going to do a chest x-ray. We will draw CBCs and CRPs just to make sure there's not an infection. It resolves fairly quickly within 72 hours. However, it's typically 24 to 48 hours before we start seeing some of those changes. What are we going to do for them? Nasal cannula. We've also done oxygen hoods. We will NG or gavage feed them until the respiratory status drops to closer to normal and their grunting starts to go down, keeping them warm, keeping that environment low stim, clustering of cares. All right, respiratory distress syndrome. This is lung immaturity either due to lung immaturity or lack of surfactant due to asphyxia, infection, cold stress, other issues with the baby. Males can have respiratory distress. Moms that have diabetes can lead to a child with respiratory distress. A C-section can lead to respiratory distress because of the stressful environment or even the fact that those pulmonary fluid didn't leave all the way. Not all kids that have TTN will have respiratory distress. They are two different things. It is more common in males that are African and Hispanic, then Caucasian, and then it goes to the females. In these babies, we are going to see grunting, flaring of the nares, lots of retractions, seesaw respiration, cyanosis. Their heart's going to be beating really fast. There's going to be crackles. Their respiratory rate's going to be high, 60s, 70s, 80s, 90s, but it doesn't typically get into the hundreds. Their lungs aren't going to be fully expanded. What else are we going to see? Flappy, tired babies, things like that. We'll do a CBC, CRPs, blood gases, blood sugars, chest x-rays, all of those good things. Let's see, what else will we do? These kids will get CPAP. They may even get ventilated. They will get ventilated if we feel like we have to give them surfactant because that has to go directly into the lungs. So we'll have to put an enterotracheal tube in. We do sometimes give nitric oxide. This will help correct the acidosis that is going on. We want to keep them warm. Antibiotics, we will start before we even get the cultures back. We will give them vasopressors as well if needed, clustering of cares, low stim environment, frequent vitals. They will be NPO for at least a day or two, and then we'll go ahead and start NG feeds. So CVN or NVN, lipids, possibly PICC lines. What else might we do? Keeping them warm, talking to the parents, things like that. we have found that these babies, if they sleep prone or side lying, that helps with their respiratory drive and their work of breathing. This is where that important education comes in, that I can do this in the hospital because these babies are being monitored and eyes on them 24 hours a day. And we don't do this at home because we can't keep that close eye on them. And then as soon as the respiratory distress goes down, we will start putting them back on their backs. We allow the parents to help as much as they can. Good assessment techniques, suction, things like that. We also use the Silverman-Ackerman scoring, which should be on the next slide. If you have a chance, go ahead and look up this YouTube link. You can really see the grunting and the flaring, or the grunting and the retractions on this baby. All right, so this is the Silverman-Ackerman scoring system. We don't necessarily use this in my NICU, but we do look at these things. So we see how that chest is moving. If it's synchronized, we're not typically as scared or worried as if we start seeing that actual seesaw. Intercostal retraction, so up there around the neck. Xiphoid retractions below the ribs. We'll also see intercostal along the ribs, how severely their nares are dilating, and if I can hear the grunting with a stethoscope or just by walking down the hall. The higher the number, the sicker the baby typically. RDS can be super scary, but these babies do recover from it. They can kind of rally and do really well for a day or two, and then they can go downhill again. But these babies are pretty strong. Probably antibiotics for at least 7 days because a lot of the times there's an infection going on. That's it. We will start with meconium aspiration in class on Tuesday.